Hey everyone, and welcome. If you're a nursing student, you already know that psychopharmacology can feel, well, like a lot. Today, we're going to slice right through that complexity. Think of this as your practical guide to the essential psych drugs you're going to see, and maybe more importantly, the critical side effects you absolutely have to know. So, let's jump right in.
And why is this so critical? Well, let's start with this number right here, 18.1%. That's how many adults in the US have an anxiety disorder. And you know what? That's just one category of mental illness. As a nurse, you are going to be on the front lines caring for these very patients.
So, here's our game plan. We're going to start with the why, the story of the brain's chemistry. Then, we'll walk through the three big categories of drugs, for anxiety, for mood disorders, and for psychosis. And we'll wrap it all up with the most important piece of the puzzle, your role in keeping patients safe.
All right, first things first, we need a foundation. The leading theory, the one that drives most of what we do, is that a lot of mental health disorders come from a chemical imbalance in the brain, specifically an imbalance of these little messengers called neurotransmitters.
And a key piece of that is this thing called the biogenic amine hypothesis. It's a fancy name for a simple idea, that depression might come from not enough of certain neurotransmitters, like serotonin, and that mania might come from too much. This is the core concept that almost all of our modern drug therapies are built on.
Okay, so keeping that idea of chemical balance in mind, let's tackle our first class of drugs. We're going to start with anxiolytics, which are the go-to medications for managing anxiety.
The most well-known anxiolytics are, of course, the benzodiazepines. You know them, Xanax, Ativan, Valium. So how do they work? Well, they boost the effect of a neurotransmitter called GABA. Think of GABA as the brain's brake pedal. By making that brake pedal more effective, benzos basically tell an overactive central nervous system to just calm down.
And here's a fantastic little clinical pearl for you. Need to spot a benzo on a patient's chart fast? Just look for the drugs that end in PAM, lorazepam, diazepam. It's a simple trick, but trust me, it'll save you a ton of time.
Now, as a nurse, safety is always priority number one. And the biggest risk with benzos is CNS depression. We're talking about anything from drowsiness to confusion, all the way to life-threatening respiratory depression. And this effect is amplified like crazy when it's mixed with alcohol or opioids. They can also be addictive, and you have to be incredibly careful with older adults because that sedation really increases their risk of falling.
But benzos aren't the only game in town. Let's compare them to another drug, buspirone. It's a totally different beast. See, benzos work fast. Buspirone takes weeks to kick in and has to be taken on a strict schedule. So what's the trade-off? Well, it doesn't have that sedation risk, and it doesn't have the potential for dependency, which makes it a much different tool for more long-term anxiety management. All right, moving on. Next up, we've got the drugs that help manage affective disorders. So everything from the extreme highs of mania to the crushing lows of depression. I want you to just stare at this number for a second. This is the therapeutic range for lithium, a classic mood stabilizer. It is incredibly narrow. I mean, we are talking about a razor-thin margin here. A level just a tiny bit above 1.2 can be toxic, and that is why frequent blood tests are absolutely non-negotiable for any patient taking it.
And here's another critical, life-saving pearl you have to teach your patients. The body kind of gets confused between lithium and sodium. It can't really tell them apart. So if a patient's sodium level drops, maybe they're sweating a lot or go on a low-salt diet, their kidneys will try to hold on to lithium to make up for it. And what happens? Their blood levels can shoot right into the toxic range. So a consistent sodium intake is key.
Now let's talk about antidepressants. You know, one of the biggest hurdles here is just managing expectations. Look at this timeline. It can take 4, sometimes even 6 weeks to feel the full benefit. And here's the really tough part. Patients often feel the side effects before they feel any better. This is a huge reason why people stop taking their meds, and your encouragement during this waiting period is absolutely vital.
So you might wonder, why are SSRIs like Prozac and Zoloft prescribed so much more often than the older tricyclics or TCAs? Well, this slide breaks it down perfectly. TCAs have some really nasty side effects. We're talking dry mouth, constipation, and they are incredibly dangerous in an overdose. SSRIs aren't without their own problems for sure, but their safety profile is just so much better. That's why they became the first choice for doctors.
There's another older class of drugs you have to know about, the MAOIs. And with these, there is one giant, flashing red warning light, a hypertensive crisis.
This is a true medical emergency, and it's triggered by an interaction with a substance called tyramine that's hiding in a lot of common foods.
And this table gives you a snapshot of what that really means for a patient's diet. The must-avoid list is full of things like aged cheeses, cured meats like pepperoni or salami, and even some red wines. So teaching your patient about this diet isn't just a good idea, it is literally life-saving. Now, even though SSRIs are much safer in an overdose, they do carry their own serious risk, serotonin syndrome. This is what happens when you get way too much serotonin in the brain, which can happen if you combine multiple drugs that boost serotonin. The key things you need to watch for are agitation, a super fast heart rate, and muscle spasms. It can be fatal if you don't catch it and treat it.
Okay, let's switch gears to our third major category, antipsychotics. These are used for illnesses like schizophrenia. The theory that guides us here is called the dopamine hypothesis. Basically, the idea that psychosis is caused by way too much dopamine activity in the brain.
Antipsychotics are pretty much split into two big groups. You've got the first generation or conventional drugs. They're amazing at blocking dopamine and really help with things like hallucinations. But they have a high risk of causing some pretty serious movement disorders. Then you have the second generation or atypicals. They have a lower risk of those movement problems, but they bring a whole new issue to the table, a high risk of metabolic syndrome. We're talking major weight gain and even diabetes. It's a tough trade-off.
And these right here, these are the big must-know side effects. Extrapyramidal symptoms, or EPS, are those drug-induced movement issues. Tardive dyskinesia, TD, is a devastating and often permanent condition with involuntary movements. And then there's neuroleptic malignant syndrome, NMMS, which is rare but is an absolute medical emergency. As a nurse, you have to be able to spot these.
Now, within that atypical group, there's one drug that's in a class all by itself, clozapine. It can work wonders when nothing else does, but it has a black box warning for agranulocytosis. That's a huge, potentially fatal drop in the white blood cells that fight infection. And this is exactly why any patient on clozapine needs strict, consistent blood work, no exceptions.
Okay, so this brings us to the final, and I think the most important section. We've talked about all these drugs and side effects. Now let's talk about your job as the guardian of patient safety.
Your role really boils down to these 4 pillars. First, you assess your patient before you even start. Then, you monitor them constantly, watching for the good effects and the bad ones. Third, you educate. You teach them everything they need to know. And finally, you promote adherence, because none of these drugs work if people don't take them. This is the nursing process in action, right here.
So I want to leave you with this question to carry with you into your practice. Every single drug we talked about today is a powerful tool, but it's also a double-edged sword. Your entire job in psychopharmacology is to walk that fine line, to maximize the good, minimize the harm, and, in doing so, build a foundation of safety and trust with every single patient you care for.